is going to work first time, but I'm trying to brainstorm. Because a lot of times for me, pictures work. So you have your lungs. And that doesn't really look like lungs, but you know what I'm saying. Okay. And so you have your level of acid, okay, that can keep your blood normal. Your level of acid, and then you've got your little kidneys. So between the two of them, they maintain your acid, so your pH is 7.4, right? Now, if your kidneys don't work, your acid level is going to jump up, right? Because your kidneys get rid of some acid too, just not as good as your lungs. So if I have to be this level and this level, if this level jumps up, my lungs then have to work harder to get rid of my acid. So it evens out. So my CO2 is going to drop, even though I'm acid, because my kidneys can't help and get rid of it. That's why my CO2 level is lower in a situation where it's not my lungs, but either my kidneys or some other situation. Does that make sense?
What chemically is going on, like during diabetes, though? I mean,
in a diabetic state, okay, when you go like ketoacidosis or something like that, you ever watch those doctor shows where they're hyperventilating or they're not ventilating at all? So something has caused them to either breathe faster or not breathe faster because of whatever the other condition is.
yeah. What is the something
What is the something?
that has caused them?
Well, again, if it's cardiac failure, right, are you oxygenating your body? No. Okay. So again, you're not blowing off your CO2. In the case of like an acidosis, okay, you're blowing off your ketones, so therefore you're blowing off your CO2. Okay, does that make sense?
Yeah.
So then again, your CO2 is going to be dropping even though you're in an acidosis state, because you're in ketoacidosis. Make sense? Okay. I love the picture thing helping out. You know somebody is in ketoacidosis, you know what the breast smells like?
Sugar, acid.
Acetone. Fingernail polish remover. Let me pass this around. I haven't done that in a while. Use your own sheet. All right. But if you forget your sheet, I don't normally let you use somebody else's, simply because I let a student had forgotten their sheet, and I let her use another student's sheet. The other student's sheet was wrong, which meant she got it wrong, and then it all was my fault because I let her use somebody else's sheet. So, normally I do not. However, last year somebody forgot their sheet. It's very, very difficult to pass this test without your sheet. Okay? And somebody had actually made a copy of their sheet. So I asked the class as a whole, are you guys okay with her using the second copy? Because I didn't want to be the only one saying yes you can, to where I was the bad guy. So if you guys want to make a copy of your sheet to give to somebody in case they forget that, you're more than welcome to. But
On my sheet, I wrote like the normal range for pH while we were talking about it. I mean, do you want me to cross out like any extra?
Well, I did the same thing when we were talking about pH.
and that's fine.
I mean,
That's fine. But just don't put electrolyte stuff on there and iron stuff and all that. But it's your respiratory sheet, so if you need something on there that makes sense, that's fine. Okay, I have no problem with that.
You did the wrong way. Oh, today's the 9th? What? Oh. What? I'm so confused. So should I just like scratch that out?
Now a lot of this you probably
Yeah, they
already
did.
talked about in your analysis, or if you haven't, then you probably will. This is another one that
I could have
crosses
just,
both.
yeah, I could have just changed that to the 9th instead of, I don't know, I'll ask her.
Your electrolytes basically keep your body in neutrality, right? Keep you normal. They have an electrical charge and kind of keep you normal. Anion are negatively charged, cations are positively charged. You probably remember that. The anion gap. So if we are measuring your electrolytes, your sodium, potassium, chloride, and your CO2, okay, the machine is going to calculate an anion gap. Okay. A lot of times the anion gap is not something that reports to the physician. It doesn't state this, it doesn't give the physician any information on the state of the patient. It gives you information on the state of your instrument. Okay? If your anion gaps are way whacked out, it's not that all your patients are dying. It's because your instrument is not right. I told you that ISEs are very difficult to keep from wandering. What do they call it? It's not wandering. Drifting. Okay, your electrolytes will drift. All right? So you will know that your electrolytes drift because your anion gaps are all going to be like whacked out. You never, ever, ever want to release a result if your anion gap is a negative number. That means your patient is dead. But your patient is not dead. Your instrument has a problem. Your electrolytes have drifted. Okay? So what do you have to do? You have to go back and actually recalibrate. Okay? You have to recalibrate your machine, rerun your controls, and get them back in. Now, I'm not saying, and most anion gaps are 7 or above, between 7 and 10 mostly. Let's say on a particular instrument. So if I had my CA240, and you're going to know what's normal for your instrument when you get there. Okay, that's something they're going to tell you. So on our instrument, we want it between 7 and 10. And I can honestly say 99% of the patients that come through are 7 or 8. Okay? You may occasionally get one that's 6. And you'd look and say, oh yeah, their electrolytes are a little messed up, so okay, I get that. But then when the next patient comes off at 6, and then the next patient comes off at 5, you're thinking, oh no, there's a problem. Okay, this is a very good interview question. Okay, when you go for an interview, the big ones that students always come back and say, they ask me what my MCHC meant. MCHC means your instrument's not working right, because patients with an MCHC over 40 aren't alive. And if they just walked into your lab and got their blood drawn and you report an MCHC of 45, there's something wrong with your machine, right? Cold agglutinin, right? Clumping, something like that. Same with your chemistry analyzer. You never want to put out a negative, because that means your instrument isn't correct. Okay? Patients aren't all dying if your instrument is. So again, that's something that they might ask you. At the advisory committee meeting the other day, that was something that they wanted Jean and I to stress with the students, is when is it acceptable to turn out your patient results? And they were like, can you just like flip-flop your level 3 control with your level 1 control, so that when they see that, they'll know that it's not right or whatever. And I'm like, but you got to realize we don't have in-date reagents, we don't have in-date controls. I can't tell you that the controls are good because they may not be giving the right results. I said, but what I can do, so I'm going to do this with you next week, is tell you the patient is normal, but give you some abnormal, so that you would say, oh wait, you know, this is somebody supposed to be normal, we shouldn't report out this result. And then one of the clinical sites said that it's something that he does with the students when they're there, is he gives them a hemolyzed specimen and shows him, and then you see the results. And you would know nitrogen of potassium of 16, okay? Or he would give them a lipidic specimen, and so your protein would be 200. Well, you know you don't have a protein of 200, 6 to 8 is normal. So he said he does that with the students, and I think they all got it. There's another thing they brought up, and Jean and I are just kind of looking at each other, kind of shaking our heads, so I'm not sure how that was gonna come up, but I don't wanna give you that one. And I won't freak you out, because it would freak me out. It's gonna freak me out, anyway. But in all honesty, at the advisory committee, one of the ladies says, we've never been in your lab. We always have the meeting in a different room. I've never been seen your lab. So we don't even know what you're, so Jean actually gave a tour through the lab, and they saw how small it is. And, you know, Jean's like, so consider, 12, 15 people in here, and then even more if you have an instructor or a lab assistant, right? So I think they kind of got it a little bit, kind of eased up on us. They're looking for it. Did you know BJC has 80 openings? 80.
Oh, MLT?
Or MTs, 80.
What?
80 openings right now.
They
Because she was
decide
like, do you
to
have
go
any
with
students
other
out there?
applicants, though.
So a lot of them want to do what you're doing.
Lab assistant?
A lot of them said that because at St. Elizabeth's, they saw how that worked.
Oh.
Because they were able to take the lab assistants and hire them. So Mary from St. Elizabeth's was there and had mentioned you, and that's something that they want to do every year, and possibly even take 2. So you have 2 lab assistants that they would then hire, because it did work with Jack and them. And then, is it Children's?
Children's is pretty much offering me a job as a lab assistant right now.
I think it was Children's who said they wanted to do it as well.
That's where my clinical side is, so she wants me to start working. Ellen?
Yeah.
One of the requirements at Barnes, you have to work in a lab for 2 years. But, like, when I filled an application over there, like, they told me I had to have, oh, if you talk to the manager, like, the lab manager, like, personally, like, they'll try to work with you, but HR told me that, I had to have 2 years in a lab experience.
To be a lab assistant?
And that's a big problem that not just Barnes is having, St. Elizabeth's is having that as well. Because in the job description it says, and yes, that's a pipe dream, we would love to have somebody with 2 years experience, but then the lab managers are saying, come to us, bring us your application, we'll pass you through. So you're right, it's getting through that door.
Because I couldn't finish the application process.
And that's the sad part.
Yeah.
is
See, I
that they're
lied,
kicking out
put in
people.
17, and they
Yeah,
still
they
won't.
said-
They're like, yeah, we're gonna review other people. 17 applications at BJC, and each one's come back saying, no, we
Yeah.
don't want you.
And so our lab manager is aware of that, so she's physically doing it different, which you're not supposed to, but she's physically doing it different. But that is a problem. So yeah, it would be, I wish I'd have thought about that, I could have brought it up at the meeting.
Do they know if they have like full-time with BJC? Did she say that she was like, or what?
80 positions, that's all she said, so I'm assuming it's a little bit of everything.
That's crazy.
But you gotta think about how big BJC is. I mean, the Memorial is BJC, and then you got all the BJC in St. Louis.
And they each have their own sections too. And like I know people who like only work in one part. They don't work in a little bit of everything. They only work in one part for all of those.
And that's gonna really depend on what hospital you're at. Because at Memorial East, it's not that way. And even though they're BJC, they do it all. So again, it's gonna, the bigger the hospital, the more departmentalized. So,
It's nice.
yeah. Which one did you go to?
Barnes.
Oh, in St. Louis? Yeah.
So did they actually say that they want the students to apply? Because when we apply, and then just like she said, that they
I
Kick
think
you
they
out.
mainly wanna go through Jean
first.
to see who we have as students, who would be interested. Because it seemed like that's the avenue they wanted to go to. That they wanted to go through Jean to see what she had and try to get them in the back door as lab assistants. Because everybody was like, they were gonna go through Jean as a contact.
See, Jean's actually given us emails saying, hey, you need to contact this person at Children's or at, I think Children's and.
So she already does that with you guys?
She does that with us, but every time I've contacted them, they're like, okay, well, you need to apply. And I do, and then it gets kicked out because I don't have 2 years, or for whatever reason, I don't even know if they ever see it.
And you're contacting the person that Jean told you. Well, then I don't know. Then I would have to go to Jean and say, I tried this and I got kicked out. I don't know. I do know that, like I said, at the advisory committee meeting, they were basically wanting to go through Jean to try to get them
Jean said she's wanting a student in there. Has a student volunteered?
I'm sorry?
Jean said she's wanting a student to volunteer for those advisory meetings. Has anybody volunteered for that?
We didn't have a student the other night, but we always want a student representative.
I will have her do it, just to get more information.
I cannot hear you. I don't know why I cannot hear
She
you.
talks
It's not
really
just the mask. It's like I
She
can't.
talks really slow.
If nobody wants to do it this semester, I've got more than enough time to do it.
Well, again,
I
talk to
just don't know.
Jean, because I think she said she was looking for a volunteer, didn't she? And nobody came or something?
She mentioned it too, but I thought somebody else had volunteered. I was just holding them out.
Yeah, yeah, because we didn't have one the other night, because we always like to have a student,
Okay.
you know, volunteer, whatever. Oh, they're all saying that they had
So
jobs.
okay, so would the program like get more people in the program? Like would they like get more than like 12? Or would they do that?
We had actually a couple years ago actually toyed with that, of putting in a second group,
Yeah.
because we can only have only 14 chairs in the lab. So you would have to come up with a way. I mean, I can lecture to 28 people and then just have 2 separate labs. But then the problem, and so we were thinking, well, that would be, you know, new instructors or new whatever.
Yeah.
But the problem is how if you, so let's say you had your lecture in the middle of the day, and the first group came to lab in the morning, and the second group lab came in the afternoon. How would all that work? So. It is.
It's been a long week.
Osmolality, it's where you have stuff that's dissolved in your urine. You've probably talked about this in your analysis, right? I know we've talked about this a little bit in instrumentation. Tonicity is your balance of water. ISE, elective ion selective electrode. That's what does your electrolytes. Those are just estimations. So your body water is about 40 to 75% of your total body weight. Okay, so if you take a diuretic, because you got to go weigh in, you know, you'll lose a lot of weight. Functions of your water solvent: transport nutrients, determine your cell volume, remove waste and coolant. So you have to think about this, okay? When the Mississippi River is really, really low, can the barges flow? No. So you need to keep yourself hydrated, because your white cells can't get to infection, and your clotting factors and everything else can't get to where they need to go. So keep yourself hydrated. Even if you're not keeping anything down, little sips of cold water helps it absorb it. So just some information that's not on this PowerPoint. In your intracellular fluid, so that's what? Your fluid inside your cells is about 2/3 of your water. In your extracellular, that's everything outside of your cells, right? Extracellular is 1/3. So intracellular is 2/3, extracellular is 1/3.
And the extracellular would be like the water between
It's not
between
in, so you get
membranes.
your blood and your joint fluid and that stuff that's not actually in the blood. Okay, females have more water than males. Gee, don't we know that? It is a fact. Females have more than males. And your body water content decreases with age and obesity.
Is there a set of changes or it gets less?
Less. Your body water decreases. So like we all
Obesity
get
is-
dried up like little poops.
Age and obesity.
Age and obesity.
Fat cells are mostly water, so why is it obesity that it decreases?
Apparently it's not mostly water.
Cholesterol and lipids then?
Apparently. Yep. Okay. Let's see. Water is freely flowing through your body. You know that. Electrolytes influence your body flow. So it's maintained by your intake of food and fluids, which we know. You eat watermelon, you got more water than when you don't eat watermelon, right? And then again, excretion, your GI fluids, sweat, respiration, urine. I mean, there's nothing magical there. Isotonic, no change in volume. So when you did your counts in hematology, did you not want to use an isotonic saline, right, to keep your red cells whole? Okay, but when you were counting your white cells, what did you need to do?
First.
You needed to burst them, right? So again, hypotonic would cause them to shrink, but you wanted hypertonic, you wanted them to swell and eventually burst, right? Regulation of blood volume, and I heard Jean lecturing on this the other day. So I'm thinking, well, gee, okay, they've already had that one. So if your blood pressure drops, or if you have a decrease in blood flow, okay, you would have a decrease, so again, decrease in renal blood flow kicks in your renin, which converts to angiotensin, and then angiotensin 1, and then angiotensin 2, vasoconstriction, which increases your blood pressure, and then your aldosterone, and then your sodium and chloride reabsorption in your tubules. So again, she lectured on this the other day, so this should not be any surprise, right? I stood out there, sat in the other room, and I heard. So I thought, okay, I already knew. What are you gonna know for me? For me, you're gonna know that if your blood flow, renal blood flow drops, can be caused from a decrease in blood pressure or a decrease in blood volume. What would cause a decrease in blood volume? Injury, blood loss. Okay. The first thing your body is going to do is secrete renin.
Do we need to
That
know?
other stuff is urine stuff.
So
Sorry?
do we need to know renal?
For her class you do. Osmolality, your water control. So in chemistry, we test either serum or urine, and usually if you get one, you might as well get out your controls for both, because about a half an hour to an hour, the second specimen's going to get there. Okay, usually always run both. So an increase in your osmolality causes a decrease in freezing point. So remember from who did osmolality for their instrumentation? Okay, so remember we talked about if you've got water on the roads, what do they do to keep your roads from freezing up? Put salt on it, because the more stuff you have in it, the increase in osmolality, more stuff in your urine, the lower the temperature is going to have to be to get it to freeze. Okay, and so we measure it by an osmometer. We make little vesicles in the lab. We do. We take a little teeny sample of your urine, we drop it into a bath of antifreeze, super cool it, and then it triggers it by a little metal wire kind of thing, triggers it, and then it instantly freezes, and the wire measures the temperature at which it immediately freezes. Okay? All right. So normal ranges are up there, 24-hour urine, or 24-hour urine. So again, you can read through that. There's nothing exciting there. What do you need to know from me? That we measure urine or serum osmolality in chemistry by freezing point depression. The more stuff in your urine or in your serum, the lower you have to drop the temperature. In chemistry, one of the big things is the difference between your serum and your urine. That's why a lot of times I do it twice. Is more for brain function. So like for brain trauma or coma state or something like that, it will, the difference in your urine and your serum is a big key for that. Hyperosmolality, so an increase in your osmolality caused by dehydration. You get less water, but you still got stuff, right? Alcohol intoxication, hyperglycemia, calcemia, uremia. Hypo is found in the presence of hyponatremia. So natremia is sodium, yes. So hypoosmolality in the presence of hyponatremia. When you eat a meal that's heavy in salt, say you're eating sushi and you're dipping your sushi in your soy sauce, which is nothing but sodium, right? So how do you feel the next day? Your rings don't really fit. You feel like you just, you know, you're an Oompa Loompa, right? You're all bloated out, okay? So again, so your sodium really affects how much water you keep or how much water you don't. So if you're hypoosmo, which means you have a decreased amount of stuff in your water, would it not make sense that you don't have very much sodium? Because if your sodium makes you hold water, if your sodium's low, you're not going to be holding water, right? In excess water ingestion, your osmolality will be decreased. Suppressing your ADH, your antidiuretic hormone. No ADH, you have diabetes insipidus. These people, have you ever seen those baby dolls where you kind of feed it in and it just goes automatically to the diaper? Baby dolls, you know, it's just a tube from the mouth. Well, that's basically what you are if you have diabetes insipidus. You don't have that, your kidneys don't have that ability to retain or let go of water. It just lets it go. So these people are drinking all the time and going all the time. It's literally just like an open tube. They're miserable. Okay. If you're hyponatremia, if you have decreased sodium in your blood, we have had where they've put people in the hospital and because everybody knows drinking water is good, right? You have to drink so much, but some people take it to an excess and overdrink and flush out too much stuff out of their system, and so they put them in the hospital and then limit the amount of liquid they can have to see if they can get their sodium level back to normal, to see if that's the problem versus something else. So, again, don't drink too much. Too much water can be a bad thing. So functions of your electrolytes. So volume and osmotic regulation are your sodium, chloride, and potassium. Myocardial rhythm and contractibility, potassium, magnesium, and calcium. Now in this lecture we're going to talk about potassium. Magnesium and calcium will be in the trace elements one that we'll do on Wednesday. Cofactors, we've talked about some of those for our enzyme lecture. Neuromuscular excitability, that's your potassium, calcium, and magnesium. And so anyway, just kind of a little overview of some of your electrolytes and what they do for you. So sodium is the most abundant cation. Cations are positively charged. Okay? Question?
No, sorry.
Oh, that's okay. 90% of all your potassium is in your extracellular fluid, not intracellular. So does hemolysis affect your sodium?
Not really.
Not really. You got it. Normal range 135 to 145 milliequivalents per liter. Less than 120 is critical. That's going to be a value that you're going to have to call to a physician. Less than 120. It is critical. Okay. Again, maintaining your osmotic pressure. One of the main things for sodium. So your sodium concentration is 15 times higher in your extracellular fluid, which means it's higher on the outside, okay, than on the inside. To help maintain the gradient, there's an active transport that moves 3 sodiums out for 2 potassium in. Your sodium-potassium pump. 3 out, 2 in. Okay. One of the problems with people with MS is that we have holes in our cellular membrane on our nerve cells where potassium can leak out. You need potassium for nerve function. Okay. So one of the medications I take is actually a medication to plug those little holes so that my potassium doesn't leak out of my cells. So to help that along, I drink things like orange juice and eat bananas and things that keep my potassium high because I walk better. Anyway, it helps. Hypernatremia. You have a high sodium in your blood, greater than 145. I can honestly say we do not see this very often. We really do not see this very often. So again, dehydrated, absolute sodium excess is really because of an increase in your sodium intake. So your absolute sodium excess is usually because you had that meal of sushi with your soy sauce and you had more in your system. Okay. Again, you can read through all that. Okay. Hyponatremia, we honestly see more than hyper. Okay. and usually it is because you've either lost it due to, working out. Have you ever licked your arm or done anything or wiped your brow and then, got something out of your teeth and you're like, wow, that's really salty, right? So you lose your salt in your sweat. You're after walking. Prolonged vomiting, we can lose it. Persistent diarrhea, okay. Inappropriate diuretic use, so people who take diuretics to try to lose weight, okay. So if you have lost or your sodium intake is low and you've lost it through sweating or prolonged vomiting, what kicks in is your thirst. So you get that I want to get something to drink, right? And so if you're just drinking water, is that going to help you all that much? So if you're an athlete, what are you told to drink? What are you drinking? Mountain Dew that's blue? Oh, okay. I was thinking it was a Gatorade or something. I didn't know that blue Mountain Dew. Like electrolytes, right? Your Pedialyte, right? You mentioned that earlier. Your Pedialyte. Delusional, again, that's where you get water overload. So then we put you in the hospital and we restrict your water. So again, you can read through all that. Nothing too exciting there. Potassium is the major intracellular cation. 200 times greater in your cells than out of your cells. So does hemolysis affect your potassium? Yes, severely, okay? Normal range, 3.5 to 5.0. Less than 3 is critical. You need potassium for neuromuscular excitability. Again, that nerve impulse down, message down your nerves, and for the contraction of your heart. So here's a question for you. So did we talk about the people who, I don't think it was this class. We didn't talk about vending machines falling on people in this class, did we? Okay, must be my own class. Okay, so if you have a person who likes to shake the vending machine to either get free food or because their chips have stuck, okay, and the vending machine falls on them, okay, crush victims. Not necessarily a vending machine, but any kind of a crush victim. When you lift that off of them, do you understand that, again, potassium is intracellular, right? If you lift that off of them, you're going to get a flood of potassium, and it can stop their heart. So you think you're doing a nice thing by lifting that vending machine off of them, but in all actuality, you can kill them. Because there are people who are crush victims, okay? And the first thing you want to do is get off whatever it is that's crushing them, and then they die because of that flood of potassium. So if you've ever watched those doctor shows, you will notice that, they'll say, no, don't get it off of them until you can get an IV started, give something to counteract that flood of potassium so that they don't die of a heart attack when you get whatever it is off of them. Okay? Now, I mean, if it's just on a foot or something, okay, get the vending machine off of them if you can, but you get my drift.
Even like when a car, like say if they're in a car accident, car just going, they automatically be right?
Well, I mean, they can either die from that, or again, when you're lifting the car off of them, but by then I'm sure you've asked for help. I mean, you and your next door neighbor aren't going to lift the car off this person. You're going to call EMS and they're going to come get the car off the person and do whatever it is that they need to do.
Is this one of the reasons why hemolytic anemias are so dangerous? Because
Sure.
of potassium being released?
Sure. Let's see. Potassium's reabsorb nearly all, or your kidneys reabsorb nearly all of your potassium. Potassium will be secreted in your distal tubules, again, due to aldosterone. Special concerns, shift of potassium from your cells, again, prolonged tourniquet, so again, that's why you got your 2 minutes, right, so your hemoconcentration. Repeated fist clenching can increase your potassium, and of course hemolysis. So again, because it's intracellular, not extracellular. Hyperkalemia, excess intake, again, can either be oral or by an IV. Cellular loss can cause it because you have tissue breakdowns. That's what you were talking about with your hemolytic anemia, right? Cellular loss. Extreme exercise can increase it by 2. So again, you can read through there. Nothing too exciting there either. Hypo can be from GI loss. Here's where I was looking for it before. Use of laxatives. So like you have those not weightlifter, who's it that has it? Wrestlers who have to make a weight class to get in to make sure that they're wrestling whoever is the same weight as them, I'm not sure. But anyway, a lot of times they will take laxatives to help them get to their weight loss, and so that's a problem. Renal loss, RTA, it's not up there, but it's renal tubular acidosis. If you want to know what RTA was, it's just renal tubular acidosis. And it is important to know that a low potassium will cause an increase in your cardiac muscle and excitability and can lead to arrhythmias, so your heart won't be beating at a good rate. Okay. Again, cardiac function. Chloride is the major extracellular anion, so it's negatively charged. Normal range 92 to 108. Here your HCO3 diffuses out of your cells and your chloride diffuses into your cells for chloride shift. Definition of chloride shift. HCO3 diffuses out of the cells and chloride diffuses into the cells for electric balance. In case you didn't know what a chloride shift was. Hyperchloremia goes along with hypernatremia. Remember, what is sodium chloride? Salt. You got it. So again, maybe due to a loss of bicarbonate, and there's some reasons for that one. Here's your good old respiratory alkalosis. Hypochloremia is a decrease in your chloride, GI loss, so prolonged vomiting. So why do you have a decrease in the chloride with prolonged vomiting? What are you vomiting? Panic acid. What's in your gut? So then you know when you're vomiting so bad, you get to that horrible, nasty, icky green stuff at the very bottom, and that because you don't have any food to dilute it down anymore, that's your hydrochloric acid. Yes, that's why people who have what's that disease that they cause themselves? I'm sorry? Bulimia. A lot of times they'll have erosion of their teeth simply because of the acid that's constantly coming up. Okay? For anybody that has GERD or that acid reflux that comes up from their gut, again, can cause problems too. So yeah, nothing exciting there, so hypochloremia. Bicarbonate, that's your CO2 or your HCO3, which is H2O and CO2. Most abundant anion in your extracellular fluid. Normal range 22 to 29. I think yesterday I told you 22 to 28, so shoot me. And then your total CO2 is your bicarbonate ion, your carbonic acid, and your dissolved CO2. So that kind of tells you where it all rolls into. Yes, ma'am?
Are we going to need to memorize all of these normal ranges?
Yes, ma'am.
Start now.
I gave you that sheet that had your Chem 8, correct? But I see your sodium, potassium, chloride, CO2 is on there. So yes.
Are those the only ones that we've been doing? Because I thought that hit like several more. I realized we only got.
It's on that sheet I gave you, your sodium, potassium, chloride, CO2.
So it's HCO3 the same thing as CO2 then for the total normal range?
HCO3 is, well, that's something that respiratory measures, not in the lab. In the lab, we're going to measure your CO2. That's just basically your total CO2.
So what you want here on our Chem 8 is the total CO2, which is that number?
22 to 29, yes.
I'm just going to say total CO2, so
That's fine. to memorize things like 6.3 to 8.1 for your protein or whatever, what I really would stress to you is to pick, to not worry about those little points here and there. Potassium is very important though, because that one's pretty narrow. But like for my total protein, in my head it's 6 to 8. For my glucose, 165 to 100, or I'm sorry, 65 to 100. I don't really nitnoid on the little teeny points because is that going to trigger me into a critical value? No. But if it's bigger than that, I mean, a protein of 3, would that be a problem? Normal 6 to 8, protein of 3, you're going to say, yeah, okay, that's not right. But a protein of 5.9, when I know a normal 6, is that going to keep me into a problem? You know, so we're going to go through that kind of as a helpful hint onto what remember. If I remember correctly, and I will double check on this, on your registry exam, if they give you a question, they give you the normal value. Because everybody's normals are not exactly the same.
NQ, is that
Milli equivalents per liter. Measurement of your total CO2, again, your ion selective electrode, just like with your other ones, okay. It is important to remember that CO2 is a volatile gas, so it can escape from your tube, okay. So again, prolonged exposure to the atmosphere, you'll lose about 2 to 3 milliequivalents of CO2. So you need to keep your specimen capped, okay. So whenever we have a critical value, depending on what it is, the CO2 is 1, we have to repeat it before we turn it out, just to verify that the machine didn't burp or do whatever. What I have learned as a tech through millions of years of running specimens, you put the specimen without the cap on the machine, all right? And it goes through and it runs it, all right? And so you get a CO2 of 42. 40 would be your high critical, let's say, okay? You have to put it on for repeat. It's not unusual that your repeat value would say be 40. So I wouldn't have to call the critical value, all right? So depending upon how you feel about calling your zillions of critical values that you have to call and how frustrating it is that you have to document who you called it to, when you called it, and all that good stuff, are you going to report out the 42 or the 40? You got to report out the 40, so especially if it's really close. You just probably take the one that's not the critical value and report it out. Which one was the better result? 42, because that was the first one with your specimen, yeah. And so, again, it's that call, but 40 is still high, so they're still going to do something about it. And then you don't have to jump through all the hoops to call it. And that's just going to be one of those that you're going to notice varies from your first run to your second run. And again, it's just from. So if you have a specimen and say the doctor ordered a glucose, which you know that having the cap off doesn't matter, and you took the cap off and you put it on the machine, and then the rack kind of got set off to the side and forgot, and then a little while later they call for an add-on, which you know they do all the time, right? You have to go find that specimen. And if that specimen's been sitting on the counter without the cap on, if they've added on electrolytes, is that specimen any good? So again, you want to put it in the refrigerator with the cap on, keep it cold. Again, your CO2 is part of your buffer system. Decreased in metabolic acidosis. Increased in alkalosis. Pretty much what we talked about yesterday. That's it. I know we went through that really, really fast. But it's Friday and we want to go do lab and go home, right? But do you have any questions?
Was there a value for calcium and I just missed it?
Is there what?
A value for calcium?
There is, but that is in your minerals and trace element lecture. As a mental range, you want to think 8 to 10. I'm going to give you like 8.2 to 10 point whatever, but as a mental, you just want to think 8 to 10. Higher in children? Lower in children? Higher in children. So your test is not going to be on Wednesday. You know, you have Jean on Monday and Tuesday. You have me Wednesday, Thursday, Friday. So your test will not be on Wednesday. It will be, we'll finish up your lecture on Wednesday. And then you guys can tell me if you want to have it on Thursday or you want to have it on Friday. It doesn't matter to me. So just continue on with more lecture materials. If you don't want to add in new stuff on top of old stuff, you don't have to. You guys can tell me. Next week is going to also be kind of our catch-up week for all the little things that we have to kind of tie in. Lab math and sustainability